This is the lab interpretation guide for the Destiny Well thyroid profile. There's a hierarchy of hormones, with adrenal hormones like cortisol ahead of thyroid hormones, ahead of sex steroid hormones like estrogen and progesterone in women and testosterone in men. If someone has a severe adrenal problem like Addison's disease where they don't produce adequate amounts of cortisol, then it may be a life-threatening condition. The salts in their blood like sodium and potassium can be way out of balance, but it also affects the production and function of other hormones, so their thyroid hormone may be low as well. And just addressing the adrenal problem by fixing the cortisol can actually normalize the thyroid without any separate treatment for the thyroid. Similarly, if someone, say a woman, has a thyroid problem and her thyroid function is low, she has hypothyroidism, then her periods may be irregular, she might have problems like infertility, in addition to the typical symptoms of low thyroid. So fixing the thyroid for her might normalize her sex steroids, might normalize her estrogen and her progesterone, get her cycles back to normal, and even fix infertility. We measure at Destiny Well the free hormones, the free T3 and the free T4. There are total amounts of those you can measure in the blood called total T4 and total T3. Those are somewhat less relevant because a lot of it is tightly bound to proteins and are not available for the cells. The free T4 is critical in the feedback loop in terms of what the brain sees and the signals it sends to the thyroid to make more or less thyroid hormone. And the free T3 is probably the most critical. It's the active form of thyroid hormone that the cells see that tells them to regulate their metabolism and many other important functions. There's also another hormone that's rarely measured called the RT3 or the reverse T3. If you've been to a doctor and you haven't gotten the explanation you need, or all your thyroid tests look normal, but you still have symptoms of hypothyroidism, you're cold, you're sluggish, you're tired, you have a lot of fatigue, many other symptoms like that, then measuring the RT3 can see if this inactive form or blocking form of the T3 hormone is actually interfering with your thyroid function at the cellular level. I've trained many doctors and many medical students over the years, and thyroid hormones are tricky to understand, but there are a lot of things we can do about them on a practical level. Lifestyle things, lifestyle changes, things that can affect the T3 to RT3 ratio, that's how active your hormones are, nutritional things that will affect this metabolism. And so especially if you're not feeling better after the usual interventions or after just normalizing your thyroid hormones, it may be time to check the RT3. At Destiny Well, we define laboratory ranges in a sophisticated way. We use the standard ranges, represented by the blue bar here, from each reference lab that does a particular test to define the lab high and the lab low. If you have thyroid test results that are too low based on the lab's formal norm, then you have a diagnosis of lab low thyroid function or hypothyroidism. Similarly, for glucose, if you have a lab high blood sugar of over 126 on 2 occasions, then you meet the formal diagnosis criteria for diabetes. That's needed to make a medical diagnosis. But at Destiny Well, we think that there can be a lot more nuance. We believe that there's often an optimal range based on what we have found going forward helps people to live the healthiest lives, to be the healthiest, and to avoid disease. We triangulate this with the medical literature, with other people's standards, with our clinical practice experience, and all the different data points we can get, so we can come up with what we believe is optimal for a particular test result. Destiny Well also, in the red bars here, will define a Destiny Well high and a Destiny Well low. These may or may not line up exactly with a laboratory high or low, because sometimes we think that the range can be higher or lower, or that it needs to be different. And in between the optimal and the green bar and the low and the high in the red bars, we have orange zones for moderately high and moderately low. They're not quite optimal, but they're not in the high or low zone. Most thyroid hormone released from the thyroid gland is the T4. Some of that gets bound to protein, and then some of it is free circulating around in the system. In the cells, especially the liver, the majority of T4 is converted into T3. If the gut microbiome, the bacteria in the gut are healthy, about 20% of the thyroid hormone is converted from the T4 to the active T3 there. then it's reabsorbed back into the circulation and goes to the cells. We also mentioned that adrenal function is critical. The thyroid needs normal adrenal function, normal cortisol levels in order to produce adequate thyroid hormone and for it to work at the cellular level. This is one of my favorite diagrams. It shows the feedback loop and how the brain and the thyroid work together and how they talk to each other. A brain area called the hypothalamus puts out a hormone called TRH, or thyrotropin releasing hormone. That goes down to the anterior pituitary, which is also in the brain. The pituitary gland is where the TSH, or thyroid stimulating hormone, is made. Thyroid stimulating hormone does exactly what it says. It stimulates the thyroid to make thyroid hormone. Most of what it puts out is T4, but about 7% of its output is active T3 hormone. Then, when the T3, T4 hormone increases, it gets into balance, and things like low body temperature go back up to normal, heart rate, blood pressure, bowel function, many things that were out of balance normalize when the T3 and the T4 concentrations are normal. When the brain sees adequate or increased amounts of T3 and T4, then it stops sending out extra signal of TSH, and the TSH level goes down. So when everything's working normally, that's how the thyroid and the brain talk to each other and how they regulate each other. This is where it gets tricky. Most doctors and most patients assume that all thyroid problems happen at the level of the thyroid gland. When a thyroid problem, either too high or too low, either hyper or hypothyroidism, happens in the level of the thyroid gland, it's called primary hyperthyroidism for too high and primary hypothyroidism for too low. That's the way most doctors look at thyroid tests and interpret them. What that fails to recognize is that sometimes the problem is in the brain, and that's called secondary or tertiary. If it's at the level of the pituitary in the brain, it's secondary, and if it's at the level of the hypothalamus or higher, it's called tertiary. The reason that's important is that they have somewhat opposite and differing effects on what the tests look like, and they may look like hyperthyroidism when it's actually hypo, or hypo when it's actually hyper, if you're just looking at the TSH and you don't check the other hormones. Primary thyroid problems happen at the level of the thyroid gland itself. Primary hypothyroidism is one of the most common conditions we encounter in medical practice. Hypothyroidism usually comes from something called Hashimoto's thyroiditis, after the doctor who discovered that antibodies were attacking the thyroid in an autoimmune fashion and destroying its ability to secrete thyroid hormone. This is the main kind of primary hypothyroidism we see, but nutritional deficiencies and other problems can also cause this. Hyperthyroidism can also be autoimmune, that's called Graves' disease, or you can have a thyroid nodule that doesn't respond to the feedback loops and just keeps putting out more and more thyroid hormone on its own and doesn't recognize or respond to the signals from the pituitary and the hypothalamus. Both of those conditions, primary hyper and primary hypothyroidism, are in the expected direction that we see for thyroid tests because what we're looking for most of the time is we're looking for the responses we would see as if the condition were primary. But in the back of our mind, we always have to keep in mind that it could be secondary or tertiary. If the problem is in the brain, then the problem is whether the pituitary and the hypothalamus signaling the pituitary send the right signal. If it's secondary, that's a pituitary problem, and if it's tertiary, it's the hypothalamus that sends the signals to the pituitary. So for instance, if the brain just puts out too much TSH, say you have an adenoma or a benign tumor of the brain and it sends out too much TSH signal, it just keeps sending that signal because the tumor is secreting that, then the thyroid will respond and produce more thyroid hormone. The same thing is true if there's damage to the pituitary. Sometimes after childbirth, people get a condition where they have a hemorrhage into that area or they have bleeding into the brain that destroys that, or people who've had brain tumors or radiation or damage to the brain, they may lose the ability to secrete TSH. Then they have a secondary tertiary problem in terms of not producing the TSH, and if the signal is not sent to the thyroid, then the thyroid doesn't know to make thyroid hormone. TSH is the most commonly measured thyroid hormone. As we discussed, many doctors don't measure anything other than TSH. But for me, that's like looking at a jigsaw puzzle with only one piece. If the puzzle has 5 or 6 or 7 pieces, you get a lot more complete picture of what's actually going on if you put them all together than if you just look at a single piece. TSH has a reference lab range of 0.4 on the low and 4.0 on the high. At Destiny Well, we think the optimal level of TSH is 1.8 to 3.0, with values over 3 representing thyroid function in primary hypothyroidism that is too low. 90 to 95% of the population have a TSH under 3, and so we think it makes sense to be in the range below that. We think a value of under 0.4 is too low, and between 0.5 and 1.7 may also be on the low side. So here's why thyroid functions are so tricky for most people. It's not intuitive, but it is true that an elevated TSH means low thyroid function in primary hypothyroidism at the level of the thyroid gland. TSH is the signal from the brain to the thyroid gland to make more thyroid hormones. In the most common condition, the primary hypothyroidism that occurs from Hashimoto's thyroiditis, where the gland is attacked by autoimmune disease, or other conditions at the level of the thyroid gland, where the thyroid is not making adequate hormone, then the brain says, I'm not receiving enough thyroid hormone, I should put out the stimulating hormone, the TSH, to tell the thyroid gland to make more. So while intuitively we think, oh, TSH is the main thyroid test, if it's high, that must mean my thyroid function's high. The opposite is true. It means the signal to make more thyroid hormone is high, and that happens in the setting of hypothyroidism or low thyroid function. So just remember, high TSH means low thyroid function, means hypothyroidism most of the time, because most thyroid problems happen at the level of the thyroid gland, and that's the way the brain responds, and we're measuring the brain response with a TSH. The brain is mostly responsive to free T4, which is somewhat surprising since free T3 is the active hormone throughout the rest of the body. And it's an area that can get us into trouble some because we think, oh, we have an adequate T4, everything else must be good. But that's not necessarily true because there are a number of factors, both nutritional and stress and other hormones that have to be in balance for adequate conversion of T4 into T3 and also to keep T4 from being converted into RT3, the blocking hormone. So normally, when the T4 goes up, the TSH goes down, and when the T4 goes down, that's the main hormone put out by the thyroid gland, the brain senses there's not enough T4, puts out TSH to stimulate the thyroid gland to produce more hormones. So the pattern we see in primary hypothyroidism is TSH elevated, free T4 decreased, and free T3 is also decreased. You should know, however, what we just talked about, that sometimes if the problem is at the level of the brain in the pituitary or the hypothalamus, then hypothyroidism has an almost opposite pattern. You get a decreased TSH leading to decreased T4 and T3. So instead of the brain responding, telling you to make more by putting out more TSH, it's the brain that has the problem. It doesn't put out enough TSH, and so the thyroid gland doesn't respond. So the T3 and the T4 and the free T3 and the free T4 are all low in that circumstance. This table is a good summary. It shows that in primary hypothyroidism, the thyroid gland fails to produce the hormones, and then the brain responds by upping the TSH signal. So the TSH is up, the brain is saying send more, and the free T4 and the free T3 that we measure are down because the thyroid gland is not able or willing to do that. In secondary hypothyroidism, the brain fails to send the signal to produce thyroid hormone. So the TSH is low, and the thyroid thinks everything is fine, so it has no stimulus to produce the T3 and the T4, so the free T3 and the free T4 are decreased. When we have elevated thyroid function or hyperthyroidism, if it's primary, happening at the level of the thyroid gland, then the thyroid overproduces hormones on an independent basis. It doesn't wait for the signal from the brain. It just produces elevated amounts of free T4 and free T3. And in that case, the brain responds by decreasing the TSH. It says, we have enough, we don't need to send any more. Secondary hyperthyroidism at the level of the brain is when the brain sends too much TSH signal to produce the hormone. It sends out excessive TSH. It doesn't respond to the feedback when the levels are adequate. It just keeps sending out TSH, and the thyroid keeps producing free T3 and free T4, so all three are up. Hashimoto's and Graves' disease are both autoimmune thyroid disorders. Interestingly, autoimmunity can cause low thyroid function in Hashimoto's, where the thyroid is attacked by the autoimmune process and destroyed, thus losing its ability to make adequate thyroid hormone and leading to low thyroid function or hypothyroidism. In Graves' disease, the thyroid becomes overactive from the autoimmune process and continues to release too much thyroid hormone, leading to overactivity, which even can be life-threatening. Some families have members that have both Hashimoto's and Graves' disease, and some people in their lifetime have both Hashimoto's and Graves'. Fixing the hormones without addressing the underlying cause of autoimmunity is less effective, and many people still do not feel well, because even if you replace the hormones to perfect ranges, you can still feel terrible if you have an ongoing autoimmune attack against your tissues. And autoimmune diseases also tend to run together, so you're at risk of having more than one autoimmune disease. The most commonly used marker of autoimmune thyroid function is called TPO, thyroid peroxidase antibodies, or sometimes it's also called microsomal antibodies. Obviously, the desirable amount of thyroid attacking antibodies to TPO is 0. You don't want your body attacking your thyroid gland at all. We say that the level of 1 to 34 is mildly elevated, and greater than 34 units per milliliter is elevated or abnormal TPO antibodies. Free T3 is the active form of thyroid hormone. Most free T3 is converted from free T4. A small amount of it also comes from the thyroid gland itself. About 7% is directly released into the bloodstream by the thyroid gland. The rest comes through conversion of T4 to T3 in the liver, the gut, and other tissues. Penetration into the cell is also important because if the free T3 can't get into the cell, it can't interact with the nuclear receptors at the cellular level to affect the changes that thyroid hormone does in regulating metabolism. There are many factors that affect both the production, the conversion, and the activity of thyroid hormones. As we mentioned, the main thing that the thyroid secretes is T4. The free T4 hormone circulates in the bloodstream, and some of it is converted to T3, mostly by the liver, but also by the gut. Now, T3 is the active hormone. So in terms of the production, the body needs adequate amounts of iron and iodine. Thyroid molecules are very iodine rich, and each of them has several molecules of iodine attached to it. It needs the amino acid tyrosine. It needs adequate amounts of zinc, selenium, vitamin E, B2, B3, B6, C, and D. If you have too much stress, if you have infection, trauma, or radiation, if you have fluoride or bromine in your system, those can antagonize the iodine and replace it in the molecules, making them less effective or less active. And then many toxins like pesticides, mercury, cadmium, and lead can all affect the ability of the thyroid to produce hormones, as well as autoimmune diseases. And celiac is very commonly associated with Hashimoto's hypothyroidism. So I recommend that everyone with hypothyroidism get tested for celiac. Now, once the T4 has been produced, it's not all over. The brain mostly sees T4, but many cells in the body need the active T3 hormone to regulate their metabolism and their function. So we need to convert T4 into T3. And it can either be converted into T3, or as we discussed, in situations where there's too much stress or trauma or very serious illness or other kinds of things like a low-calorie diet or overall inflammation, certain toxins, infections, liver or kidney dysfunctions, and some medicines, then T3 is decreased in production and RT3 goes up. And RT3 is not only an inactive form of thyroid hormone, it blocks T3. So the ratio of T3 to RT3 is important. Now, when the thyroid gets into the cell, it's still not complete. So it needed selenium and zinc to be converted. And then once it's in the cell to be active and effective, it needs vitamin A and zinc. And exercise is also important because it produces factors that help the thyroid function be affected in the cells. A number of nutrients are key, both for the production of thyroid hormone and for the conversion of T4 into the active T3 hormone for penetration into the cell, and in regard to the ability to interact with receptors at the cell level. These include selenium, zinc, iodine, vitamin B12, vitamin D, molybdenum, boron, copper, chromium, magnesium, manganese, iron, and vitamin E. Active thyroid hormone and increases in circulating levels of thyroid increase metabolism. The main risks of overtreatment with thyroid medicines over time are osteoporosis and atrial fibrillation. Osteoporosis is thinning of the bones that leads to fracture risk, and atrial fibrillation is an erratic heart rhythm problem that starts in the top part of the heart and is an irregular rhythm that has other risks associated with it, such as stroke. Thyroid hormone treatment has also been used outside of specifically treatment for thyroid as adjunctive treatment or augmentation for depression therapy. It's combined with antidepressant medicine sometimes to help with symptoms of depression. When someone has low thyroid function, replacement helps many different conditions. It lowers triglycerides, it makes the body form LDL cholesterol receptors and helps change LDL particle number. It helps things like muscle aches and weakness, including fibromyalgia. It's also important to optimize vitamin D whenever you have muscle aches or weakness. It can improve mood and it can improve bowel function, among other things. Our free T4 ranges, the lab reference range is 0.93 nanograms per deciliter on the low side to 1.0 nanograms per deciliter on the high side. We think 1 to 1.5, the green zone, is optimal, and we think less than 0.93, the lab normal, low, is too low. We also believe 0.93 to 0.99 is moderately low, 1.6 to 1.7 is moderately high, and again agreeing with the lab reference range, greater than 1.7 is too high. The free T3 is the active hormone. We find it to be critical, and it's what acts inside the cells. Most of the time, free T3 is a good representation of what your thyroid is doing. Occasionally, T3 will be elevated in hyperthyroidism without elevation of T4, so I always check both. Rarely, T3 won't be able to get into the cells, and you'll have what's called T3 pooling. So it looks like there's a lot of T3, but it's actually not making it into the cells where it can affect its action. For T3, the lab reference range is 2.1 picograms per milliliter to 4.3 picograms per milliliter. We feel that the optimal zone is 3.4 to 4.3, with being higher than 4.3 is too high and lower than 2.1 is too low, with 2.1 to 3.3 in a mildly low range. So what happens when you have too little thyroid hormone, when you have hypothyroidism or an underactive thyroid? Well, you get weight gain, and lots of people would love to have something specific to fix, and so we do check it in anybody who has unexplained weight gain. People often feel cold because thyroid is needed for cellular metabolism and thermogenesis. So to make heat in your body, you need metabolism, and for metabolism, every cell needs thyroid hormone. Bowel function typically slows down. People get constipated. They have foggy thinking. Their heart rate may slow. Their body temperature is low. Women will have irregular menstrual periods or even stop having cycles. That's associated with infertility. Thinning hair is common, and then cholesterol and triglycerides go up. People will also have low mood and low motivation. What about symptoms of too much or overactive thyroid, hyperthyroidism? Well, the opposite happens. You get rapid or irregular heart rates, including atrial fibrillation. Patients get unexplained weight loss. They feel hot all the time. They may have shaking or tremor. They have diarrhea or increased bowel movements. They notice increased sweating, insomnia, and anxiety. What tests are included in the Destiny Well thyroid profile? There's the TSH, thyroid stimulating hormone, both the free T4 or FT4 and free T3 or FT3 hormone. Free T4 is the main circulating reservoir of thyroid hormone, and it's what the brain sees and responds to in terms of the feedback loop between the thyroid and the brain, regulating the amounts of thyroid hormone that are produced. And free T3 is the active hormone that acts at the level of the cells. There's also the most important antibody, anti-thyroid peroxidase antibody, or anti-TPO, that goes up in most thyroid autoimmune conditions. What else can you check if you still feel like you have thyroid problems and your thyroid tests have been normal? I think it's a good idea to check your reverse T3, your RT3, and then to calculate the free T3 to RT3 ratio. It might be that the production of thyroid hormones from the thyroid gland is normal, they circulate around fine, but they're not adequately converted into free T3. Or the RT3 might be increased, so the amount that the cells see that affects their function is blocked by the RT3. So this is a critical thing to check if you've already done everything else and you still don't feel right. I also think it's important to check for celiac disease in people with thyroid problems, especially if they're autoimmune in character. Celiac disease and Hashimoto's hypothyroidism are common together because autoimmune diseases run together, and there may be mechanistic reasons that problems in the bowel can cause thyroid problems. It's also true that celiac disease goes along with Graves' disease because all autoimmune thyroid problems can have an association with celiac. Also, probably a good idea to consider testing urinary iodine and bromine levels. Iodine is a critical molecule. Several iodines are attached to each thyroid hormone molecule that are produced. So if that's inadequate or there's a problem with your iodine, you may not be producing adequate thyroid hormone. Bromine is also important. Bromine is a very close chemical cousin of iodine, and it can substitute for iodine in the synthesis of thyroid hormone. That would be fine if it worked, but it's not as effective and it can block the production. So checking your bromine level is important too. Bromine is commonly added to breads. It's also added to other baked goods and other foods. It's found in swimming pool products. It's also found in some medicines. So checking a Destiny Well celiac profile, checking the Destiny Well Advanced Thyroid Protocol Plus that has the RT3 and the FT3-RT3 ratio next time, and then considering the Destiny Well Toxic and Nutritional Elements profile to look at your iodine and bromine levels. Those can all be good next steps. At Destiny Well, we've been extremely fortunate to find some amazingly good coaches, people with backgrounds of success in varied fields who bring all sorts of resources and talent and skill to help you. These folks have many years of clinical experience, and they know how to be of assistance at every step of the way, from motivation to connecting you with the right resources to finding things that you need to get you on your journey. To learn more, go to destinywell.com/coaching to meet our team and find out how they can be of service to you.